Now I am more than glad to introduce Dr. Samad Manola. He is the renowned lifestyle medical doctor specializing in aesthetic medicine and sexology. With extensive leadership experience across healthcare, cosmetics, wellness, and fashion industries. Currently area manager for Middle East and Africa at Bariatric Switzerland. Dr. Samad, the stage is yours. Thank you.
Thank you, Dr. Siba, for this presentation. I'm really glad and honored, more than privileged to be today with you for the second edition for this wisdom and brilliant congress. And by the way, I should like to, say thank you to my dear Dr. Tina and dear Mustafa and all the board that is with us today for this awesome and brilliant congress that you are really, really amazing about it. So today I will be speaking about a subject that I am speaking about since years and years. It's much more easy to speak about women happiness, but while I am speaking about women sufferings, I have always a lot of words to say. That's why speaking about the sexual arousal about women urged me to seek for some testimonies. And I found this.
Well, I spend a lot of time thinking about how much I hate my body and my mind, and it's changing. And I'm not at the acceptance level yet with that. If I live with people. I also have a long depression and was suicidal for a while. And now I'm experiencing a great deal of anxiety, and I find it hard to leave the house.
Then I found also this.
I am leading the way through the menopause maze with my vitamins, my melatonin sleep patches, my bioidentical estrogen cream, progesterone cream, a touch of testosterone. She's a wiggle whisperer. I am. I've tricked my body into thinking it's younger.
Is it a soap opera? Is it a film? Because talking about menopause seems to be much more controversial. There are some women that are speaking about menopause with very comfort, happy things, and happy way. However, as Dr. Barbara spoke about it, she was really in depression, she was really in anxiety. That's why things that urge me more to look into the scientific researches to see why women go to facilities for the menopause. So I saw that more than 45% are the hot flashes. However, the sexual pain is represented only 21%, which urged me more to see why. Is it because they are not really suffering from sexual intercourse, or they don't have sexual troubles during their course, or because there is other things? I knew that talking about sex drive can feel very awkward. It does not depend on your country. Dear colleagues from Arab worlds, just be patient, because I was thinking about that when I was practicing in Morocco and North Africa. I was always sitting and saying, when I am going to go to Europe in order to speak about sexuality with easiness, etc. When I came to Italy, I found worst, because speaking about sex is something that is really, really awkward and seems to be like a perverse behavior. That's why the way we talk about pleasure is much more complicated between us as a physician. So can you imagine your patient speaking about pleasure, because it's a lot more important that we give a credit for. Sexuality during menopause is something much more worse to speak about it, and also some publications, which are not so many in the PubMed, make that there is a big and a great confusion about it, because all the publications, more than 90%, are speaking about hormonal therapy, and they are thinking that testosterone as Samantha Jones said, is the key. Let's take testosterone and we will be so good in our sexuality. Excuse me, testosterone is not the only solution. So sex hormones change during menopause, and you know that more than me, and it will impact our sexual life. However, and I insist on it, total testosterone was not significantly affected in this cohort that was done in a sexual study in Melbourne, and the use of testosterone does not give the real solution and the final solution about it. Pleasure is deeply connected to sex. You should know that, because we are not doing sex to have children, unfortunately. We are doing sex to practice our health, mental balance. It's not me that is saying that, it's the WHO that is saying that sex comfort is something very important for our quality of life, and the sex drive is your health power. So let's speak about this famous libido and sex drive, which is the motivational drive towards sexual activity integrating biological arousal, emotional balance, cognitive anticipation, and the contextual modulation. To make it a lot and much more simple, imagine that your libido or your sex drive is like the Birkin from Hermes. Every one of us was dreaming, always dreaming to have the Birkin. So to have the Birkin, we should have three components. Who will buy the Birkin? From where and what is the color that I am going to buy my Birkin? And where I am going to make my show off with the Birkin. So the person that is buying the Birkin, which is also the most important because they are giving money, is the neurobiological core of the libido. Without the brain control, we cannot have a sex drive. The color confusement that you have for your Birkin constitute the hormonal endocrine regulation. Without hormones, we cannot give a great libido. That's also the color of your Birkin. If you take an orange Hermes Birkin, will not be as a black or as a white Birkin that you have. And how to make the show off of your Birkin endorsement will be the psychological and the contextual modulator. Just take into consideration these three important points. Libido, when it is decreased, don't go to think about testosterone. Think about these three components that are the main things about giving a great sex drive. I'm not learning new things. As physicians, you know who control our neurobiological secretion. We have the hypothalamus that is the main master commanding all the medical preoperative area and integrate the hormonal signals. Thank you to the dopamine and thank you to the oxytocin that is the bumping hormone that is giving you pleasure and sexual arousal. And I will insist in the prefrontal cortex, which is giving us the glutamate and the GABA hormones, which are very important for our inhibition system. So when you're speaking with your patients about the libido, or when you're speaking about your patients about how you can get your sexual intercourse with your sexual partners, think about this hormone, because a lack of this hormone can give many complications even if you do the best treatment in aesthetic surgery or aesthetic medicine. As a rappel for all the hormones that are very important in our sex libido, as I told you, for the dopamine, serotonin, and also you should know that the serotonin is an inhibitor and give an inhibition for the excess of the will. Think about it when you are in front of patients that are treating depression or anxiety symptoms. The psychological context, the show off of your Birkin when you buy it from 12 Rue de Faubourg à Paris. You should see and take into your mind how are you going to present the libido and the sex drive for your patients, and how you are going to make this analysis with your patients in order to make it open and to make it not closed as it is in our context. So think about the relationships dynamics, think about the body image and the self-esteem, because most of your patients are plastic surgery addict and they are aesthetic medicine addict because they are seeking for Botox filler and for frames, but they are not seeking about the real comfort, which is the intimate part one. Now we will speak about the pathophysiology of the libido disorders, and I have again 2 essential examples. Let's listen to them.
Hello. It's over. I told my wife.
Who is this? A monogamy. I must have caught it from you people. Easy, honey. They don't call it a job for nothing. I am harsh. I'm also demanding, stubborn, self-sufficient, and always right. In bed, at the office, and everywhere else. We badly want shame on you. You badly twice, shame on me. My legs are fantastic. I have killer abs. My act is perfection. Is this the part we're not going to like? But I have decided, after careful consideration, that I might be ready for bigger boots. I'm a trisexual. I'll try anything once. But if you're a successful saleswoman in the city, you have 2 choices. You can bang your head against the wall and try to find a relationship, or you can stay screwed and just go out and have sex like a man. A guy gets angry at me, he's a pistol. A woman, she's emotional.
I love you.
I love you too, Richard. But I love me more.
Do you know Samantha Jones? Do you know Sex and the City? You're related as me. This is my preferred personality because it's just like a chapter of psychiatry. Unfortunately, she is suffering from a hyperactive or compulsive sexual drive. And in her hormones, there's a lot of dopamine, but less serotonin because she does not have inhibition anymore. And we have many symptoms and many diseases like nymphomania, bipolar disorder, substance use and hyperthyroidism, and orbifrontal dissipation. The second type of paraphysiological sexual carousal and arousal is this type of patients.
Well, my husband and I kind of live separate lives. We sleep in separate bedrooms and we're very committed to our family. We live a real family life. But I remember laying in bed one night beside him when we were still sleeping in the same bed and thinking, this is a really lonely place to be. And it felt really disheartening and uncomfortable and didn't make sense to me. I didn't understand why I was feeling that way. And at the beginning, I put a lot of blame on him, but I think there's not really a place to blame. It's just you kind of shift who you are and what you want, how you feel, and not everybody comes out of the other side in the same place they were when they went.
This is the opposite. We have a hyperactive sexual desire disorders with a lot of serotonin and less dopamine, just between blankets. We must not be always in menopause to have a decreasing sex drive, because we can have young girls, young women with a great hormone character and cartography, but with the hyperactive sexual desire. You know why? Because there is a big emotional disconnection between the body image that they have and also the way they are giving the conception for their sexuality. This is very important in front of our patients that you will have specifically for gynecologists as important to treat, to listen, much more than to hear. The clinical framework and the main physiopathologic mechanism in menopause, just to resume, the decrease of estrogen, vaginal atrophy, and reducing of lubrication and discomfort, the diminution of testosterone and the pro-hormone DHEA, decreased sexual motivation, fantasies, and arousal. The increasement of prolactin and cortisol make much more inhibition feedback on our sexuality and our sexual intercourse, and the psychosocial, I'm focusing on it, which is very important. Fatigue, body image changes, and relational detachments are to take into consideration.
All this make reducing the desire, fantasies and sexual responsiveness, like our women with her husband. We have the decreased sensitivity of orgasmic capacity, some disorders as dyspareunia, vaginal dryness and atrophy, and irritability with depressive mode. Think about a diagnostic evaluation before giving hormones to your patients. I know that many colleagues, gynecologists, are always seeking to give some gel or hormones when a patient comes to them to say, I have a disorder, I cannot penetrate a penis. That's okay, you will be fine. Some lubricants and testosterone and you will be a good person. Unfortunately, it does not give the real solution. So make, please, an endocrine, metabolic, neurotransmitter links and a gynecological checkup with the psychosexual and also checkup. This is a clinical follow-up that I am using in my facility that I can share with you. You have all the information about the patients, all the list of the hormones that I am requiring from my patients, the sexual function index, specifically the female sexual function index, FSFI, and the functional regenerated session intercourses. I can share them with you in order to have it with the protocol of your patients you have in your office. I love this slide because it's very significant, meaning that knowing where the clitoris is a knowledge, which is anatomy, but knowing where your own clitoris, that will be your power agency. There is a multiple therapeutical strategy. I will not be focusing on it. I will share it also because of the lack of time. Again, I have also a formula with this therapy, which is the clinical protocol sheet that I have for every patient that comes to my facilities, with all the baseline assessments, the therapeutic strategies, the monitoring and the follow-up. Please go for the baseline 3 months, 6 months and 12 months. Don't never give a gel or give a treatment and leave your patients in the nature. The checkup and the follow-up is something very important. The expected outcomes, of course, the increasement of the libido and the diminution of dyspareunia and anxiety, but above all, increasing the self-confidence of our patients. We should be much more centered on the patient and centered on the patient's benefits. Restores function and comfort that you know and that you are #1 in doing it as gynecologists. Address aesthetic dissatisfaction like the volume loss and the skin laxity, and support intimacy and confidence in both genders. Keeping from the men specifically present with us today that women's sexuality is not about what they want according to Daniel Goldner, but the other side of desire, the new and varnished norm for female sex drive. As long as we continue to think that man and men are hard-worked to give much more responsibility to this woman in order to seek for his pleasure and not her pleasure, we will never have a sex drive in a balance. Better women and men to approach each other as more or less equal partner in lust and work out the rest in the morning. At the end, I'd like to tell you, redefine pleasure, redefine the power. Your confidence is the most beautiful curve that you have. And the message from me, or last message from me, dear women, love yourself more. And thank you for your attention.
Thank you so much.